Hi guys. Today we're going to talk about care of the patient with non-inflammatory intestinal disorders, and this is chapter 56. So our student learning objectives is to collaborate with the interprofessional team to protect the patient with non-inflammatory intestinal disorders from injury and infection. We're going to prioritize our care to promote nutrition and comfort for patients, and we're going to treat with a colostomy, and we're going to teach about self-care. So first of all, let's take a moment and remember what our intestines do. Your small intestine has three main functions: movement, mixing, and peristalsis, digestion, and absorption. And our large intestine, again, has movement, absorption, and elimination. Obstructions. Obstructions. Hi everyone. We're going to talk today about care of the patient with non-inflammatory intestinal disorders, and this is in chapter 56. Our student objectives include collaborating with the interprofessional team to protect patients with non-inflammatory intestinal disorders from injury and infection. We're going to prioritize their care to promote nutrition and comfort for patients with non-inflammatory intestinal disorders. We're going to teach self-care with colostomies and ileostomy care as well. First of all, let's take a brief moment and remember what our intestines do. If you need more than this brief overview, I highly recommend that you look back in your A&P book. Your intestines, your small intestine, has three main functions: movement, which is mixing and peristalsis; digestion, and absorption. Your large intestine has movement, absorption, and elimination. Obstructions. Obstructions can be both mechanical and non-mechanical. Mechanical includes intussusceptions, which is a telescoping of the bowel; volvulus, which is a twisting of the bowel; adhesions, tumors, obstructions from the intestinal wall, such as strictures, fecal impactions, and even emboli. Non-mechanical is a paralytic ileus. Symptoms include distension, nausea and vomiting. They can have hypovolemia, and they have a potential for acid-base imbalances. It is important to look at chart 56-1, and that will look at both the differences in both small and large bowel obstructions, and that is on page 1123. This here gives you a showing of both the telescoping of the bowel in the intussusception and the 180-degree twist of a volvulus. Again, mechanical obstructions in the bowel is a physical blockage. It can be caused by problems outside the intestine, such as adhesions, but it can also be inside the intestinal lumen, such as tumors. Paralytic ileus. It's caused a lot of times by handling of the intestines during surgery. It can cause interruptions in peristalsis. Hypovolemia can predispose a person to ileus. Peritonitis caused by toxins in the peritoneum can cause a paralytic ileus. How do we prevent these? We walk the patient. We get them up early in the postoperative period. If they're not able to get up, we move them from side to side. But for our intents purposes, this semester, we would be able to get our patients, if we can't walk them, we can at least get them up to the chair. We need to make sure patients who are unable to get up are being turned every 2 hours. When you have a paralytic ileus, they usually they have a strict MPO, and they generally will have an NG tube, which I know you talked about during your new skills with Ms. Stone. A non-mechanical obstruction is a paralytic ileus. It does not include a physical obstruction from in or outside the intestine. Peristalsis is decreased or absent by neuromuscular disturbances, and this causes a slowing or a backup of intestinal contents. So a lot of times when people come out of surgery, no matter really what the surgery is, they are at a risk of parallelic ileus, but especially with abdominal surgeries. So you want to make sure that you're getting them up, you're getting them moving as soon as possible, so you can increase those bowel sounds and hopefully have them pass gas in a timely fashion. Assessment. There are no definitive labs. White blood cell count may be elevated if you have a strangulation or otherwise they're usually normal. You may see increases with dehydration. You may see decreases, especially with ileus, of your potassium. It can be visualized on a CT scan. It talks in the book only about a CT scan, but I guess because I have always worked at a community hospital, we do have a CT scanner. We have two, but a lot of times our surgeons will start with a KUB, which is a rate, and they're able to see the obstruction with that as well. And then if they're unable to see it, they go on with the CT scan, which is the gold standard, but it's also a lot more expensive test. And if you're able to see an obstruction with a less expensive, test, then a lot of times that's what they'll choose to do. Furthermore, in assessment, and again, all these notes are written for you in the note section that I uploaded. Assessment, you want to make sure you're collecting history of GI disorders, surgeries, treatments, family history of GI cancers. Do they have nausea and vomiting? What color is the emesis? Pain, what is the location? What makes it better? What makes it worse? Physical assessment, look at chart 56-1 for key features of bowel obstructions. Remember, mechanical obstructions of the small intestine are usually mid-abdominal pain and cramping. They can have prolonged vomiting and can lead to fluid and electrolyte imbalances. A complete obstruction, you will have no flatus or bowel movement. Partial obstruction, you may have diarrhea. A mechanical obstruction of the large bowel, you may have lower abdominal distension. And obstipation, which is where you have the absence of both flatus or a bowel movement. And they may have, if it's a partial obstruction, they may have real ribbony looking stools. They look like the curly ribbon that you put on a present. Partial obstructions generally will have a high-pitched sound and then completely absent below the obstruction. Non-mechanical obstructions, the pain is very constant and is diffuse. So what kind of nursing care can we look at? Well, first of all, we want to make sure that we check out the action alerts for nursing safety regarding NG tubes on page 1124. These patients will generally have an NG tube. They will be MPO. A lot of times they'll have IV fluids for electrolyte management. Interventions are aimed at uncovering the cause of the obstruction and relieving the obstruction. Again, look at chart 56-2 on page 1124 for the care of the NG tube. Non-surgical management of the parallelic ileus, it usually responds very well to non-surgical management, generally because surgical management is what caused the parallelic ileus anyway to begin with. Your NG tube, a Salem sump has the blue pigtail, which is the air vent. The Levine tube, which is rarely used, does not have an air vent and does not function unless it is connected to suction. An incomplete mechanical obstruction, it can be treated with an NG tube. If it is caused by a lower fecal impaction, it usually resolves after the patient has been disimpacted. They may ask you to hold opioid analgesic because this can mask a perforation, and morphine can slow intestinal motility. Non-pharm management while we're holding those analgesics can be frequent position changes, and it can be sitting the patient up in a semi-Fowler's position. Fluid and electrolyte balance, because Both fluid and electrolytes can be lost from both vomiting and NG tube drainage. You want to do fluid replacement with isotonic solutions, and sometimes they will add potassium to that. It is very important to monitor for fluid volume overload. So these patients would be on daily weights. You would make sure that you're listening to their lungs and maintaining a very accurate intake and output, including the output from NG drainage and any emesis if possible. So a lot of times when these patients are not able to be managed with non-surgical management, this is generally if it's an adhesion. You'll see exploratory lap with lysis of adhesions. That's where they're going to cut through the adhesions that have formed from previous surgeries. They'll do this surgery if there is some type of diverticulum that is causing the blockage, that kinds of things as well. But generally an exploratory lap would be, they will try everything non-surgical first. But if they do go in with a laparoscopy, a lot of time is for that lysis of adhesions. So first, let's talk about an open lap or open exploratory laparoscopy. When you have this patient is open. Usually, it's a midline incision, starting right below the diaphragm, going around the umbilicus and further down. They are MPO. They have an NG tube until bowel sounds return. Then they'll start by clamping the NG tube, seeing if the patient can first tolerate that. They'll then start with ice chips and advance the diet from there. The laparoscopic exploratory laparotomy is they generally do not have an NG tube, and they just have small incisions on the abdomen. The laparoscopic minimally invasive surgery, they do not have an NG tube, and they generally go home much sooner. Generally still not the same day, but usually the next day, these patients are able to go home, especially if it was just for lysis of adhesions or something to that effect. You do want to look at chart 56-3, home care management of care of patients suffering from fecal impactions and how to prevent fecal impactions. You want to educate these patients both for the exploratory laparoscopy, whether it's open or if it is done laparoscopically, to report abdominal pain, distension, or nausea and vomiting. And surgery home care is just usual surgery home care. Look at your incisions, make sure they're not red or angry, you don't have any drainage. Make sure you're not reading a temperature greater than 100.4. Make sure that you're able to tolerate liquids. If you're not able to tolerate liquids, give the doctor a call. Manage your pain with the least amount of pain medicine possible. Just regular surgery care. There's nothing special. They will make sure that the patient is passing flatus prior to discharge, and generally will tell them they would like them to have a bowel movement within 3 to 4 days and to call back if they have not. So let's quickly talk about polyps. Polyps are inside the bowel. They are usually they're just small growths. Most of the time they are attached to the surface of the intestine. They are asymptomatic and usually found during a colonoscopy. They are usually not a problem unless they are very large and can cause bleeding or obstruction, or again, that intussusception, which is that telescoping. They can be removed during a colonoscopy, which is called a polymectomy. Nursing care after a polymectomy includes monitoring for distension, pain, rectal bleeding, posteropurulent drainage from the rectum, and fever. A small amount of blood is normal, but it should not really be frank blood, and it should not be copious amounts. So generally the physician will tell you what amount of blood is okay for their patient. But generally you will see some, and you want to make sure the patient is aware of that.